Okay, so we'll continue where we left off before. Elior, why don't you take this case?
Okay, so here we have T1 images. I'm seeing just irregularity, kind of the articulation of the calcaneus and navicular.
Well, actually, so if we look here, so this is what you're talking about, right?
Yes.
Okay, so this is the navicular. That's actually kind of a bony prominence coming off the navicular, and this actually is a cuboid down here.
Oh, right.
If you look
Right.
over here, there's the cuboid, and then this has a very characteristic serrated edges consistent with what?
With a fibrous coalition.
Good. So that's another common location for coalitions called at the cuboid navicular coalition. Great. Okay, Robert.
All right. Let's see. Looks like there's another an osseous coalition, and I think it's the navicular and cuboid again. So.
Okay. And then let me show you some more images. So here are the axial images, and a little hard on one cut to figure out what's going on. That's the cuboid over there. Uh, so the part of the calcaneus back here. And then if we go to the choroidal images, what we see here is the talus and the calcaneus. So what bones are involved here?
So it's a talus and calcaneus.
Yeah, talus, calcaneus, and navicular are all
Okay.
coalesced with a bony coalition. So a little bit more severe disease here. Okay, Tayson.
All right. So I think this is the calcaneus has an osseous coalition with the cuboid.
Okay.
Or yeah, cuboid.
And then we can see that because of this coalition, there's a lot of abnormal stresses in the ankle joint, and you can see the severe degenerative disease involving the subtalar joint space. Yeah. And there you can see the correlation coming across. So there's calcaneal cuboid and talar navicular correlation and causing degenerative disease. You know, I just realized Oleg isn't here. Do any of you guys have his cell number and could text him? Or I can run into the other room. I'll be right back. Let me go get Oleg. Okay. Sorry about that. Elior. Okay. This patient has poorly defined symptoms. Oh, I'm sorry. Never mind. This is for me. Okay, so there we can see bony coalition and secondary degenerative disease. If you see stress injuries of the bone in the hindfoot in adolescence, you always have to consider tarsal coalition, either that or prior trauma as a cause of the disease, or infection or something. But commonly, it's going to be a coalition. if you have a poorly diagnosed, the diagnosis is very poor, you get pain that's kind of ill-defined in the area, kind of think about tarsal tunnel syndrome as a possible diagnosis. And about 50% of these are idiopathic. Most of these are, I think, due to injuries of the ligaments within the sinus tarsi with secondary instability, and then you get a lot of damage to that area and scarring and pain. Okay, Elior.
Right. So here, yeah, what catches my eye is that first metatarsal. There's deformity there. Looks
Yeah.
like a growth plate, also like kind of cutting in the middle longitudinally.
Right. And so this is here's what it looks like on the sagittal images. Very funny appearance with a kind of growth plate going across an oblique way. And this is called an epiphyseal or metaphyseal bracket. It's congenital and cause foot deformity. Okay, Robert.
All right, so we have a 17-year-old with pain for 7 months, no trauma, rule out coalition. Looking at the anterior talus, it looks like there's a prominent talar beak.
Yep.
Some edema associated with that, and then there's a lot of edema about that subtalar joint as well.
Right. So yeah, so this is the classic talar beak. And in young people, what's the first thing you think about when you see a talar beak?
Ligamentous injury, I'm not sure.
Okay, it's coalition actually. So you want to look for coalition, but you can have other congenital anomalies as well. If you notice here, we're getting impingement in the midfoot in the area of angle of Gissane with eburnation of the bone. Obviously, a lot of bone edema in areas and a prominence here. And in this particular patient, this is a less common abnormality. We can see that there's not a great definition of the medial subtalar facet. And what this is a prominent anterolateral facet. I think I'll show it better in a minute. But you can get a prominence here to the inferior talus on the right in this area, and you get an abnormal articulation between the talus and the calcaneus where there's no articular cartilage right in through here. And you can get severe degenerative disease, abnormal stress patterns with this, and edema and degenerative changes. So the anterolateral facet, it's commonly associated with calcaneal bone marrow edema, talar beaking, cortical thickening in those areas, cystic changes, subtalar soft tissue edema, and you can often get sinus tarsi edema in this area as well. Okay, this is another paper that looked at this. It's a case in young teenagers of rigid, painful flatfoot deformity. It's often associated with coalitions, and they include any of the correlations, so you have to really look for correlations. This is just another example. In a 15-year-old, we can see all this bone edema. We're not quite in the right plane, but there's a suspicion that you might have a pes planus in this particular case, but we can see this large facet here, all this eburnation and edema in the area of the angle of Gissane, marked bony edema here, and all through and here with the degenerative disease. So this is another accessory anterolateral facet here, producing another name for this is perineal spastic flatfoot deformity. And looking at it, if you look in cadavers, this is that accessory facet. Here we can see the talar beak that's often associated with it. That's the facet, which then impinges upon the calcaneus, producing this facet impingement and the eburnation, and then the abnormal stresses to the bone and the bone edema that we saw on the prior studies. Now, if you look closely, some people believe that you can see this commonly in ankles. This particular patient's paper said it was not statistically associated with symptoms. So be careful about, don't overcall this if you don't see the degenerative changes in the bone edema. That if you just see something that looks like a prominent projection of the inferior aspect of the talus in that location without the degenerative changes of the bone marrow edema, it's probably not going to be significant. But if you see it in association with the changes we just saw, it's a uncommon cause of ankle pain in adolescents. Okay, who's next?
It's me.
Okay, Tayson.
All right, we have a sagittal CT of the ankle, and there is a severe joint space loss posterior subtalar with some osteophyte formation posteriorly.
Yeah, a little osteophytes right through there, and a little bit of eburnation of that subchondral bone. If we go farther out, this is what it looks like.
Okay. Kind of have kind of this angulated articulation that I feel like we don't get.
So it really looks like the posterior, the middle facets are kind of contiguous with one another.
Yeah.
And we bring it all the way in through here. And then here we can see some marginal osteophytes, a lot of eburnation of the subchondral bone. And there are those marginal osteophytes. If we go to the coronal plane, it looks like this. So what do you think may be going on here?
Is this a coalition?
Yeah, I would really be concerned about that, and it may be a coalition, but this is in this particular case, this is really conjoined subtalar facets, and they have types that I'm going to go through here in a minute. This is type 4. So let's talk about the anatomy of the subtalar joints. A type 1 is where you have the anterior and middle facet joints are actually continuous. This is a study actually in Egyptian Calcaneal that was done actually published in India. I don't believe these numbers are correct for the US population, but it was in this one cadaver study where the majority of the time they saw continuity between the anterior and middle facets of the subtalar joint and a separate posterior facet. Type 2, they had all three separated, which is the common one I think we see in our population, where you have an anterior facet, a middle facet, and a posterior facet, which are actually separate. A type 3 is where you have an absent anterior facet, and I see that a little bit more commonly, I think, in our population, where you just see a middle and a posterior facet. And then the type 4 is one where all three facets are actually contiguous with one another. This leads to abnormal constraint of motion and degenerative changes in these patients. I don't commonly try to differentiate between these three patterns, but I just know that there are variations there, and it may be a source of degenerative changes and hindfoot pain in younger patients. Okay. Oleg, what do you think of this case?
So, there's like edema in
Well, this is a T1 weighted evidence. So
oh,
really
it cannot be.
edema.
I mean, it's the yeah. I mean, the little darker, like darker bone marrow signal in the
You mean here?
subtalar. Yeah, over there.
Okay, well, the thing I'd like you to point out here is the orientation of the bones.
Hmm.
And usually the uh, tibia is right on top of the talus, which is right on top of the calcaneus, and the forces go right through the middle of those three bones. In this particular case, we can see the middle of the tibia is there, the kind of the middle of the talus is kind of there, and the calcaneus is over here.
Okay.
So this is an anatomy called calcaneal valgus, which is different from hindfoot valgus that we're going to talk about in a little bit. And this is commonly associated with a syndrome that I don't know if we're going to talk about now or later, called adult-acquired flatfoot deformity, which is associated with insufficiency of the posterior tibialis tendon, where you lose proper medial tugging onto the to the calcaneus. The calcaneus goes into valgus like we see here, and what can happen, it can be stopped by impacting against the fibula here, which is called lateral bony impingement. And we will be talking about the different impingement syndromes later. So this is an abnormal configuration. Here it's usually in adults like this, it's usually due to chronic long-standing insufficiency of the posterior tibialis tendon, where the actual talus remodels, and we're actually you get this fixed deformity within the bones. But we're going to come back to that later. Let me see. Elior, what do you think of this case?
Right. So I think there's a coalition between the talus and the calcaneus.
Yeah, and I think that's a good thing. We can see the bone edema here. Actually, this joint space looks like it's kind of maintained. It's nice and smooth here. What this is abnormal orientation of the medial facet. The normal medial facet should be horizontal here with the floor. This is at an angle, as we see there. Let me see. So this is normal over here, and this is what we're seeing in this patient. So the orientation of the medial subtalar facet is abnormal. That's what's leading to abnormal stress patterns within the bone. So this isn't actually a correlation, though it wouldn't be terrible if you called that, because that would lead people probably to the correct way to approach it anyway. This is actually a congenital, rare congenital bony anomaly of the middle subtalar facet, where it's oriented in the wrong plane. And I usually see this a couple of times a year, so it's not extremely rare. Okay, Robert.
Okay.
Hi.
Looking at the ankle here. I don't. Okay. Yeah, so I see the peroneus brevis and longest tendons, and then I think it's the peroneus brevis muscle belly that the arrow's outlining.
Right, right. And if we look at that, we can follow it down. It comes down very low here. And this is called peroneus brevis extension. And this is, again, we've talked in the past about congenital syndromes where the muscle extends too distally and actually goes into tight spaces which are designed just for the tendon, and it could produce impingement. We talked about that in a supraspinatus muscle and tendon of the shoulder. And this is just an example of a muscle here. When you flex and extend, it can actually, the muscle can be impinged by the bone, the canal and the retinaculum of the perineal retinaculum, and can produce injuries and pain syndromes of the distal muscle. Okay, Tayson.
All right. So I see some retrocalcaneal bursal fluid, and there is a muscle kind of low lying towards the insertion of the
Okay. So we have this.
Achilles tendon, yeah.
Look here, there's this tendon here.
So maybe an accessory soleus.
Okay. And on the axial, you can see where you should have this peritenon fat, we're seeing muscle there instead. And this was a low-lying soleus, and also a muscle over here, which is fairly common, usually not described in radiology reports, which is between the perineal tendons and the really the peritenon fat, which is called the peroneus cordis muscle. I think we'll talk about the anatomy for that in a minute. But you're right. So again, it's a low-lying muscle. I saw a similar case to this, I think yesterday or the day before. And right. Okay, Oleg.
My- So, um, so
Okay,
it's
so we
the
see
posterior calcaneus.
a marker there,
Uh-huh.
calcaneus here.
Okay.
There's a muscle here.
So,
And let's go to the sagittal images.
mhm. Interesting. So again, some like low-lying muscles.
So this is on the lateral side, actually. And then we have a muscle coming down here,
So
and it's attaching to the side of the calcaneus.
nice. Um, like can be like
So you follow it up here.
uh,
Okay. It comes across here. This big muscle right in here.
like gastrocnemius, like
So
low-lying.
this is, well, this is called an accessory soleus.
Again,
muscle.
soleus muscle. Okay,
Actually,
accessory soleus muscle. Okay.
I'm sorry, this is the medial side. My error. I thought this was going to be a peroneus cordis. This is coming down on the medial side, and if you followed up, the muscle is next to the soleus, and it comes down on the medial side. It's a accessory soleus muscle.
Wow.
And occasionally these can be torn and cause symptoms. The one thing about the foot and ankle is that there are a lot of anomalies. Okay, Elior.
Okay, so here, I think we're going to look at the, like behind the peroneal tendons.
Okay, so
there's
here's the perineal here, and what is this?
That's the perineal retinaculum.
Good, that's the perineal retinaculum, perineal tendons, and then we have this funny structure right there, which is coming down and attaching to the lateral aspect of the calcaneus, which I thought we were still on with the last one. If we go to the coronal images, it looks like this. So it's coming right down through here, beside the perineal tendons, and attaching to the bone here.
Mm-hmm.
And here's what it looks like in the sagittal plane.
Another peroneus cordis.
Good. So that's the peroneus cordis. So that's where it's located, and the accessory soleus would be on this side, the medial side.
Mhm.
Okay. Robert,
Okay.
you've got Dr. Tierman to blame for this case.
I was gonna say, don't know what I'm
I can
supposed
pay.
to.
Why don't you look
Okay.
at that right there?
All right. So
These are the perineal tendons here. That's the calcaneus.
okay.
There's a structure here.
Okay. So I think that's going to be another peroneus fortis, and is it at least tendinotic if not torn?
Good. Excellent. So here it is on the axial images right next to the peroneal tendons. Here's coming down. It's no longer black here. It's thick. And this is, and here we can see it's not black where it attaches down. Now, it could be that the muscle goes distally, but this patient had trauma, and this was a pair of the peroneus cordis insertion. And you can see the edema in the surrounding soft tissues here. And PD facets would be helpful. So here's just an article in Radiographics that goes through a lot of the different variations in anatomy. Here's the peroneus cordis coming down through here. And here's the flexor digitorum accessory longus. So if you guys see something that you think is an anomaly and you're worried about it, you can, there are places to look it up. Flexor digitorum accessory, which, so there are a lot of different anomalies here. The vast majority of these are not important, except when you see some injury or abnormality and there's a structure that you doesn't fit into the normal anatomy, then you just might have to look it up and see what structure it is. Tibiocalcaneal internus. Alrighty, so it's fun and games. Tayson.
All right, so see our normal flexor tendons anterior to this, where this arrow is pointing. So it's some accessory muscle belly. Maybe it's the accessory flexor digitorum.
Good. Very good. Longest. Okay. Oleg.
Okay.
Forget the sinus tarsi syndrome here. Here are the markers where the symptoms are. Here,
It's
here the
again,
sagittal, they're the sagittal image.
the symptoms like on the top, like on the surface. Oh.
Okay, so we're dorsal here.
Dorsal, yeah. So it's like extension of the muscle instead of
Okay, good.
instead
So
of
it's like
tendons.
extension of the muscle down along the extensor tendons, and that's what it is. And this patient had symptoms right where the markers are, and that's right where the extensor retinaculum is.
Oh.
And so the muscle is extending down into a confined space and is being impinged upon by the extensor retinaculum. Good. Elior.
Okay. Prominent medial foot in a 3-month-old. On the ultrasound, I think deep to the tendons, there's these rounded, looks like calcifications.
Talk about this.
Yes, this with the shadowing artifact.
Yeah, it's a little
Maybe.
hard unless you know how it's oriented. I don't know whether this is bone or not. Here's the MR scan.
Yeah, it looks like there's muscle on the medial side of the foot, just like more muscle than I would expect.
Here are the coronal images.
Yeah, there's this hypertrophy. It looks like of that muscle.
And it's on one side versus the normal on the opposite side. And this is called congenital hypertrophy of the plantar muscles. And it can involve any one or multiple ones of these particular muscles. And it's a congenital anomaly that of the feet. And here's a 6-year-old girl who's evaluated for foot mass. And here we can see these massive plantar muscles. So it's congenital hypertrophy of the foot muscles. Now, In deformities of the foot, there are a lot of different words that are used that can be very confusing. Talipes is any congenital deformity of the foot. Pes is an acquired deformity of the foot. Valgus is distal lateral deviation. Varus is distal medial deviation. Equinus is fixed plantar flexion of the hindfoot. Calcaneus is fixed dorsiflexion of the hindfoot. Cavus is a raised longitudinal arch. And congenital cavus deformities of the foot are common, and it's a problem. Too bad John isn't here today. I thought he was going to be here today because he's done a lot of surgery on foot deformities in the past because he used to work with congenital anomalies. And then planus is flattening, pes planus. So pes is an acquired deformity of the foot. Planus would be a flat longitudinal arch, which we frequently diagnose and talk about. And then adduction is displacement toward the midline, and abduction is displacement away from the midline. So, Tayson, what do you think of this case?
Looks like an Aquinas deformity, right?
Well, let's go back here. So Aquinas is fixed plantar flexion of the hindfoot. Calcaneus is fixed dorsiflexion of the hindfoot. And cavus is a raised longitudinal arch.
Yes,
And this is actually a cavus deformity,
okay.
which unfortunately I don't have good examples of all of those to go over with you. But this is a cavus deformity and is a significant problem in young children. Okay. All right. Let me. Okay. I'm going to stop the video now so that it can process this, and I'll see you in a minute or two.